Thank you, Professor Tariq Ashraf, for the excellent talk. Now I request my next speaker, Dr. Miqdad Ali, for his talk on patient with ST Am I coming late?
I'm probably touching on some of the controversial cases that we see come across to our office every day. Nothing to disclose. As all of us know that primary PCI is the way to go, but if you lose that 12-hour window, they don't do very well. So this is very quick going through the latecomers. Their mortality is much higher. Their mobility is much higher. Same is repeated during the COVID area from Korea Acute Myocardial Infarction Registry. Exactly same copy that they have high mobility and mortality. So one of the simple things that ACC, Dr. Asad Khan just put up there, and this is a little bit more detailed about it. Things are very straightforward: cardiogenic shock or heart failure, ongoing ischemia, symptom onset, 12 hours, 24. These are relatively simple decisions we make. But there are cases where they present to our offices a bit late, and then you have to make decision whether to do something interventionally or not, and that's a little more involved decision. So I'll go through some of the guidelines. Are we following the guidelines? And if not, then what it needs correction, especially in this time and age of this Sehat card interventions, which I call Sehat card interventions, in which people are very enthusiastic about doing things that are not supposed to be done. So why are patients confused at times by their doctors? They go from one office to another office. One guy says, do this. The other one says, don't do anything. The third one says, no, you need bypass. This brings a lot of confusion, not only to the patient, but the patient's family, along with different physicians involved. So I'll give you a very simple example. 75 years old, frail lady with intralateral myocardial infarction 4 weeks back. Pain-free but short of breath with minimal activities, well-ambulated, LVF is 25%. These are real cases. Past history remarkable for multiple heart attacks. According to the family, she undergoes a viability study done at the primary hospital. The STEMI viability study actually shows that there's not much viability there. And he recommends maximum medical therapy. Our son takes her for a second opinion to another hospital because she's not feeling well, she was not getting better. And the second doctors again ask for, he looks at the viability study and he says, you know what, this is not good viability data on technetium or thallium. Let's do a PET scan, FDG PET scan. So FDG PET scan is done, and of course there's more viability, and he recommends coronary angiogram. The coronary angiogram shows a triple vessel disease with a syntax score of 28. So he recommends bypass surgery because based on if you go by the guidelines, his ejection fraction is 25%, his syntax score is high, so he recommends CABG. Well, the family doesn't like CABG. They go for a third opinion, and they say, let's see if we can have a little better doctor. So they hand over again one viability, another viability, and this guy says, well, you know, I believe in WDME stress echoes for a reason. So let's do a DSC, simple test, non-invasive. So they go for it, and of course, this study shows that except for the inferior wall, the rest of the myocardium gets better. So he recommends, third cardiologist recommends a 2-vessel PCI plus assist device or CABG because a person is not getting better on maximum medical therapy. So the patient's confused, the family is confused. We'll come to this story again. So if you look at should we intervene following thrombolysis, a SWIFT study, 800 patients, they underwent PCI 2 to 7 days after myocardial infarction and post-lytic. No benefit, in fact, this in randomized data. This was followed by concept of this salvage and rescue, which does carry weight, and we'll show some cases there. 50% resolution of ST elevation 90 minutes post thrombolysis and their REACT and rescue trials. And it shows reduced mortality. So there's this ping pong going on. On one side, data shows, yeah, it's helpful. On other says it's no benefit. What's the reason? Well, then this comes the pharmacoinvasive therapy, that's the drip and ship for the high-risk patient. You give them medication and ship it to a better hospital. I'm not going to go through what are the big, just for the time's sake of, we're going to go forward. But anyway, there's some high-risk patient that they were getting these infusion therapy and transferred to a bigger hospital. Well, this did not show much improvement, although there are different combination, glycoprotein 2,3B inhibitors, reduced lytic therapy, and then transferring to improve the flow there and seeing if they do better. ASCENT-4 PCI trials, similar thing, and terminated because they are higher bleeding, significant higher bleeding and MIs. So MACE was with the facilitated PCI 19%, in fact higher, though the TIMI flow was better. Finis, similar story. Again, drug to balloon time was 2.2 hours, combination, all combinations are given there, and no benefit, just higher bleeding. And looking at the overall study, the true pioneer of the primary PCI, Cindy Grimes, because this confusing thing were coming up and down, so what was found that people who had TIMI3 flow at the baseline did better, irrespective of what you do. This is Cindy Grimes' data, 17 trials, 2,000 patients, and facilitated PCI, primary PCI. And what she came up with was that actually the mortality was more. Bleeding was more, hemorrhagic strokes were more. So what do we do with these missed crowds, the people who don't get to a good tertiary care place for getting primary PCI? As a cardiologist, how often do we see confused patients or confusing doctors, in fact? And how often do we ask, is it an appropriate case for PCI? How do I base my decision? The answer is follow the guidelines, and most of the time you would be better off. So let me give you a few examples. 65 years old gentleman with cabbage history, inferior wall MI, lytic is given 4 hours, and still having chest pain, 4-hour post-lytic therapy, same ST elevations, brought into the cath lab, proximal RCA disease, stented. So this is a salvage PCI with class 2A indication. 45-year-old smoker, infraposterior wall myocardial infarction, 48 hours earlier, who received lytic and have somewhat vague chest discomfort, transferred to your hospital as a part of invasive therapy. You can see the changes there. Still having some pain, circumflex artery stenosis, and was stented. Again, this is a class 2B indication. I'm giving you some examples as how they are treated differently and what is the indication, and are we doing something that's appropriate, or the appropriate criteria is pretty bad. So this is a patient, again, 40-year-old anterior wall myocardial infarction, 36 hours earlier, transferred to your hospital, invasive strategy. He's young, he's asymptomatic, he's well off, 120/80, pulse is fine, no discomfort, ECG, anterior wall myocardial infarction. Coronary angiogram is next morning, he's loaded with clopidogrel, and the next day you see this picture, proximal total occlusion and no flow, in fact, in the LAD territory. So this is a fresh occlusion. He's a young guy. But if you look at the OATS data, which was more than 2,000 patients, and doing a PCI in this guy is totally inappropriate. We are seeing in this Sehat card era, people are doing PCIs left and right, and they are not looking at, is it indicated, is it EUC stands where. So the appropriate use criteria is almost none. It shouldn't have been done. ACC, AHA guidelines so very clearly is asymptomatic, but I will do it. How often have we seen physicians who will say, oh yeah, it's a fresh occlusion, it's not costing anything, let me do it. How often we have seen improvement in these LVs? We have done it. We haven't seen much improvement. I'm skipping some of the slides, but my point is very simple. Go with what the guidelines say. Don't become, we see these physicians at times who say, no, I'll do it because he's a young guy, he's a relative, they can afford it. Don't do it. You're not doing any good to the patient, you're doing it just for your own. Thank you. I'm stopping because of the time. Thank you.
Thank you, Dr. Miqdad, for the wonderful presentation. Now, last speaker for today, Dr. Karman Babar. He'll be talking about unusual presentation of osteoinflammation MI and their management.